Hello, and welcome to the National Press Foundation's Evelyn Y. Davis Studios in Washington, D.C. My name is Rachel Jones, and I'm the Director of Journalism Initiatives with NPF. Thank you for joining us for the COVID, RSV, and flu Making Sense of the Fall Respiratory Illness Season webinar, sponsored by Champions for Vaccine Education, Equity, and Progress Initiative, also known as CVEP. The organization has resources and information in English and Spanish to help you learn more about different respiratory diseases, including COVID-19, flu, and RSV, and how to stay protected against severe illness through vaccines and treatments. For more information, you can scan the QR code on the screen or go to cveep.org. Every year, millions of people are affected by COVID, respiratory syncytial virus, and flu. Last week, the FDA approved 2 new COVID vaccines and strongly recommended that the most vulnerable people get updated booster shots. Following our last webinar that explored the summer wave of increasing cases of COVID, today's conversation will pivot toward the fall respiratory illness season and what the public needs to know about updating their vaccines and protecting their families from serious illness. We'll hear from 5 speakers whose expertise will guide us. First, we're joined by Dr. Brendan Jackson. He is the Senior Advisor for Preparedness and Response for the CDC's National Center for Immunization and Respiratory Diseases. He previously served as Incident Manager of the agency's COVID response and lead of the CDC's combined response for COVID, influenza, and RSV this past fall and winter virus season. Next, we'll hear from Dr. Ada Stewart, who's a family physician with Cooperative Health in Columbia, South Carolina. She's also past board chair of the American Academy of Family Physicians and a past president. Dr. Stewart currently serves as a chair of the inaugural AAFP Commission on Diversity, Equity, and Inclusiveness in Family Medicine. We'll also hear from Dr. Amesh Adalja. He is a senior scholar at the Johns Hopkins Center for Health Security, an adjunct assistant professor at the Johns Hopkins Bloomberg School of Public Health, and an affiliate of the Johns Hopkins Center for Global Health. His work is focused on emerging infectious disease, pandemic preparedness, and biosecurity. Next, Legia Navarro joins us from Toronto, Canada. Legia is an award-winning bilingual journalist working in long-form narrative print and audio with a focus on health and Latin stories in the United States and abroad for outlets including Al Jazeera, the Associated Press, and the Christian Science Monitor. She's also living with long COVID, and she has reported extensively on this topic. And finally, we're joined by Fenit Nirapil, one of the Washington Post's health and science team reporters. He covers public health, infectious disease, and LGBTQ issues. He joined the team in 2020 to cover the coronavirus pandemic and previously spent 5 years on the local politics team. You can read the full bios for all of our panelists on our website at nationalpress.org. Now, for everyone tuning in, you can also submit questions for these panelists at any time in the chat or by using the Q&A features, and we'll try to get to as many of them as we can. First, I'd like to start with you, Dr. Jackson. In your role as someone with a broad expertise and a scope on this issue, what's the takeaway message that we should have about this summer wave of COVID? And tell us how researchers might be using what they've learned in the development of vaccines and treatments.
Sure. I think one of the things to start out with is just a reminder that COVID is definitely still with us. It has certainly changed from where we were several years ago. It is not the emergency that it once was, but it's still clearly a public health threat, as you mentioned. There were nearly 1 million hospitalizations last year from COVID, maybe 75,000 deaths approximately. It's a problem for a lot of people. And it's also a reminder that it's different from some of the other respiratory viruses. They are all somewhat different from each other. Flu and RSV are almost gone during the summer in the United States, whereas COVID, we know every year that it's been with us. We have seen a wave of, a little bit of difference in exact timing and a little difference in the height, but it is definitely here. I know there's a lot of talk out there about, does the current vaccine schedule make sense? And that's a really complicated issue. There's a lot of factors that go into sort of uptake and, the timing of all that. But I think what's clear is we know that vaccines, as you mentioned, are just right around the corner. They've already been approved. They're starting to work their way through the system into offices and pharmacies around the country. And so it's a really good time to go ahead and get vaccinated, because we've seen that the fall sort of dip downwards is rarely as far down as it is during the spring. So it's going to stay probably at a pretty high level before going up again in a couple of months, if the past is any indication.
And could you remind us what those two new vaccines are?
Sure. So in short, there's the Pfizer and the Moderna-based vaccines, and they're available for everybody ages 6 months and older. And again, it doesn't matter how many vaccines you've had in the past, how many infections you've had in the past, unless they were within the past couple months specifically, and we can talk about that later. Just go ahead and get those updated vaccines. We're also anticipating there may be approval of another type of vaccine made by Novavax. This one's different. It's not mRNA. It's a protein subunit-based vaccine, and we may be seeing that in the coming weeks be approved as well.
Let's move to you, Dr. Stewart. You're someone who spends time talking with families and seeing patients and families in clinical settings. What have you seen during this summer wave? And tell us about that.
Thank you so very much. And it's really important to recognize that, I am on the front lines, and the summer has been really difficult for us in the practice setting, because we are seeing the increased number of individuals who are becoming positive for COVID-19. And I was pleased to see that we now have the updated vaccine, that we as family physicians are excited that we now have an opportunity to decrease the number of individuals who end up having serious disease or even death due to COVID. Those numbers over this past summer has been unbelievable. I can tell you, even last week, every day we had, at least within my practice, 5 individuals who were positive for COVID-19. And that's not to say that we have not already seen individuals who are positive for the flu. So now is the time. Now is the time for individuals to get vaccinated. And it's exciting that we have the opportunity to immunize individuals with flu, RSV, as well as COVID at the same time.
Dr. Adalja, with your expertise in emergency preparedness, how would you rate the public's overall response to vaccination 4 years into COVID?
I think the only way you can rate it is that it's very concerning, that what we've seen is an erosion in the public's perception of the value of vaccines. And I think this is something that's been going on for a long, long time, but really accelerated or took on a new flavor during COVID, when you saw so much anti-vaccine activity going on. They were basically energized. And now that has spilled into other vaccines, that we're seeing lower rates of childhood immunizations. We're seeing measles outbreaks ensuing because of that. We're seeing less vaccination against influenza. We saw a kind of tepid uptake of updated COVID-19 vaccines. And I think that's the kind of the long tail of this pandemic, is that it was harnessed by the anti-vaccine movement to really get their message out there. And I think that doesn't bode well for us, because that means that there's going to be more preventable infections occurring. That means that our job is a lot harder now to convince people that what they heard was misinformation. And I think this is one of the biggest threats that we face when it comes to vaccines, which really should be valued just like a new iPhone is valued. People run to go get a new iPhone. They should be running to get new vaccines.
Legia, I want to talk with you. Obviously, our audience is primarily journalists, and so I think your perspective as a journalist who's not only a health expert and has covered this, but you're also living with long COVID. So could you start by telling us about your experience and when you received your diagnosis and how things have been?
Yeah, it's been really, really difficult. I first became ill in January of 2021, but it wasn't clear what was wrong because I had never knowingly had a case of COVID. So I was very, very ill, but not with COVID symptoms, instead with extreme, really, really extreme fatigue, pain, shortness of breath, dizziness upon standing. I couldn't really walk. So I spent 3 or 4 months pretty much in bed. Then when I got my first vaccine shot in April of 2021, I improved almost overnight. And within 2 weeks, I was pretty much at my level of health that I'd been before I became ill in January of that year. And so that clued my doctors into the fact that I had likely had an asymptomatic case of COVID that had then resulted in long COVID. And so we were able to kind of look back in time, and my child had had COVID symptoms in April of 2020, but there was no way to get any testing at that point. So so that was, it was great information to have, but quickly my symptoms, started to come back. And by the end of 2021, I couldn't walk to the park to take my kid, a couple of blocks. And then in January of 2022, at the height of Omicron, I got reinfected. Again, spent pretty much months in bed, and I haven't really improved since then. Luckily, my cognitive function has improved a bit because there were points where I could not understand. For example, I couldn't understand TV when I was watching it. I needed to use subtitles. I had great difficulty finding words, remembering things. My memory is still really, really, really shot. And so my life since January 2022 is that I am a wheelchair user now because I cannot stand up to leave home. I have a heart condition that's very, very common among people with long COVID called POTS, or postural orthostatic tachycardia syndrome, which basically means that when I stand up, my heart rate goes up and my blood pressure drops. So the blood ends up, my blood ends up in my legs and it's not making it back up to my brain. So I become very short of breath, faint, dizzy, and lightheaded. And so, so I use a wheelchair. I have to take a shower seated, and even that is extremely, extremely difficult for me. It takes me days in bed to recover from. I spend months at a time at home in the winter because I have nerve pain caused by COVID damaging the nerves in my legs. And because I live in Canada and it's pretty much winter 6 months out of the year, I spend about 6 months of the year without being able to leave home. And what I really want people to understand, among other things about long COVID, is the reverberating impact. This has, upended my life. I'm only able to work 10 or 15 hours a week, usually, sometimes not even that. But my whole family's life has been changed dramatically. My partner is my caregiver and has had to fight for accommodation to be able to work from home, to be able to take care of me because I can't cook, for example. Our child is homeschooled, and we're pretty much shut out from society because people don't mask anymore. People don't isolate when they're ill. So we can't go inside anywhere. Other than the only times that we do go inside anywhere are for urgent medical appointments a few times a year. But other than that, we are shut out of society. We are, as well as the millions of other people with long COVID and their families.
This is a powerful testimony of impact, and I'm definitely going to want to come back to you to find out more about how journalists can get at these stories. But Finnet, you see this emerging research almost on a daily basis, and I'm sure you interact with hundreds of researchers and experts. So I just wanted to ask you to tell us about your reporting on the summer wave and how you've had to pivot now to think about how you're going to develop stories about the fall respiratory illness season.
Sure. So I've been covering the pandemic in earnest on a national scale since that very first winter surge that we had in 2020, 2021. So I've been thinking a lot about how to cover these waves and how to cover the advent of vaccines. So on one side, it's very exciting that we have immunizations for all the major respiratory pathogens with RSV, flu, and COVID. But there are also a lot of misconceptions that I've seen readers have that we as journalists can do to help educate them. And especially, we can go into more detail than public health agencies often can, because public health agencies face the pressures of being practical and being simple. But when we're trying to inform our readers, we can go a little deeper sometimes. So, on one side, I think there's a lot of misconceptions that the vaccines don't do anything for infection, because people hear about their vaccinated friend who got sick. You don't hear about the person who was exposed to COVID but didn't get sick because of the antibodies and protections that they have from vaccination. So I do think it's important to include that context, that there is research that suggests that vaccines do increase protection against both infection and transmission. It's not the kind of nearly foolproof protection that we see from other vaccines like measles, but it does do things to help prevent against infection and transmission. And oftentimes you hear public health agencies emphasize hospitalizations and severe outcomes, but that's not the primary concern for a lot of people, especially for those who are at risk of severe illness. And a lot of people do want to avoid getting sick outright, and the vaccines do offer some protection on that front. And then I would also caution people on how we cast COVID as being a fall/winter respiratory virus, because although with the vaccine it's being treated as part of a broader fall respiratory virus vaccine campaign, COVID is not a seasonal fall/winter respiratory virus, as Dr. Jackson explained at the outset. And every summer I hear people being taken aback that, oh wow, if COVID is still around, what's this summer cold that's happening? So when we're writing about it, I do think it's worth emphasizing that although we typically see the biggest COVID wave happening in the wintertime, it is the kind of pathogen that's year round. And we don't entirely know if it is seasonal, or the summer waves, for example, could be a result of new variants emerging in the virus, evolving at a time that positions it to surge again in the summertime. So there's a lot that we still don't know about how the virus operates. So I would encourage people to include context from both interviews with experts and public health agencies when trying to contextualize all this information for readers. And then the other thing I would encourage journalists to focus on is writing about the consequences of the federal government no longer treating COVID as a public health emergency. Vaccines went from being treated as a public good to now being treated as a commercial product. That means that people are up to the mercy of all the other problems with our American healthcare system. Last fall, we saw a lot of issues with people trying to get insurance to cover their coronavirus vaccines, and hopefully they should have been mostly resolved by now. But that's something that's worth keeping an ear out for, whether you're hearing people in your audience who are running into challenges getting vaccinated, either if it's insurance denying it outright, or if there's a limited amount of places that are within insurance networks in your communities. And there's also financial pressures for some doctors' offices and pharmacies who may not be stocking it. So it's worth keeping an eye out for both availability in your community. And then lastly, the federal Bridge Access Program that provided free vaccines to uninsured and underinsured Americans has ended. So that is going to be a major difference we're seeing with this vaccine season. The CDC has said that it made $62 million available to help local and state health departments and nonprofit organizations to purchase vaccines. But what that looks like for your readers is going to really depend on where they live. So that's a worthy storyline to explore too, is what kind of opportunities are available for the most vulnerable people with some of the most inconsistent access to healthcare.
I kind of feel like I need to turn this over to you, Fennett. You have provided so much incredible information in that one statement. So thank you. Let's move back to Dr. Jackson, because I wanted to be sure that our viewers and listeners understand RSV. those who know it know that it primarily affects babies and infants, but please tell us a little bit about what we need to know about RSV and about the public education campaign that I think is going to be launching soon on it.
Sure, and I'm glad you brought it up. A couple things to point out specifically. One is that RSV is not just a big problem for infants in the United States and in young children. It is the number one cause of hospitalizations for infants here. I mean, I remember my pediatric rotation during medical school and seeing half the ward taken up in winter by children in there with RSV. And there is now ways to protect it with this new vaccine and the immunization for infants once they're born. The second is that I think, and this may be even less known, is that it is a problem for older adults. When people are in the hospital with RSV, people that are over, for example, 75, they can have as bad outcomes as they can roughly for COVID and for flu. And I think a lot of people tend to think of it as a young children disease and not realize how much it affects those older adults. One thing I'll point out this year, as compared to last year when the vaccine first became available for older adults, is that last year it sort of required a conversation with the healthcare provider. We know a lot of people don't always have a healthcare provider, or they just want to go to the pharmacy, for example. Right now, it no longer requires that. If you're over 75, you just go ahead and get that vaccine if you didn't get it last year, because it's not an annual vaccine like COVID and flu are. Or if you're 60 to 74, and you have a certain underlying health conditions that raise your risk, people can then go out and get that vaccine right there. I just in terms of the HHS campaign that's going on, that's the Health and Human Services campaign that we're helping to support. That has actually already kicked off last week. It's starting out sort of a smaller level, focusing on education around RSV, trying to emphasize those things that I just mentioned. And then next month, sort of mid-September range, is when it really kicks into gear with a lot of the ads and the outreach that you're going to be seeing. And that's not specific to RSV. That'll be encompassing those three diseases together.
Dr. Stewart, I know that obviously you see the broad range of patients and people with COVID in your practice and in your work. But let's for a minute focus on this age range of 60 to 74 and older Americans who might be at increased risk for severe illness. I saw a story just yesterday that suggested that perhaps people should wait to get their vaccines because of the timing of the virus season. And if they get it now, it wears off in 2 months, it might just be at the peak. So tell us about what you're advising older people around when to get their vaccines.
So a great question, and thank you so very much for asking that. The biggest thing that I tell my patients is now is the time to get vaccinated. What happens is when individuals wait, they tend to forget. So it is important that every opportunity that we have to talk to our patients about the importance of vaccination is an opportunity to prevent them from getting severe illnesses as well as hospitalizations. And right now, we're encouraging all our patients because the COVID vaccine, of course, is eligible now for the 2024-2025 version of this vaccine is available now for individuals 6 months and older, and recognizing that those older individuals, and I hate to say older, but I use the word more mature individuals who are more vulnerable to severe illness, they need to get vaccinated, and they need to get vaccinated as soon as possible. It does many times require a conversation with your healthcare provider, which includes your family doc, because we are that trusted resource. So if there's any question on, whether you need to get the vaccine at this time, because some individuals who have recently had COVID-19, it may be okay to delay that vaccine until 3 months after they have had symptoms. But that is a conversation to have with your healthcare provider. And so it's important to, number one, is as soon as these vaccines are available, and we know that now the COVID-19 vaccine should be coming to our office fairly soon. We already have the flu vaccine, and we are talking to our patients today about making sure that they are vaccinated.
Dr. Adalja, we have an interesting question that came in. It asks, should COVID be characterized differently than other respiratory infections? Because it was first understood to be a respiratory virus and soon became known medically and scientifically as a vascular one, and that many complications for people with severe COVID include the risk of stroke. So, is it misleading to characterize it alongside flu and RSV?
I don't necessarily think it's misleading because it is primarily a respiratory syndrome. It is transmitted via the respiratory route. It comes from a family of viruses that are well characterized as respiratory viruses. Remember, this is the seventh human coronavirus that's been discovered. And I think that, yes, it causes complications outside of the respiratory symptoms, but so does influenza, so does RSV. So in the weeks to months after an influenza, infection, you have an elevated risk of stroke, an elevated risk of heart attack. RSV, increased cardiovascular mortality after an adult gets RSV. Even after shingles, you have an enhanced rate of stroke after shingles, but shingles is not considered a cardiovascular disease. So I think what the larger point is that although a virus might have a predominant system that it impacts, there can be cascading impacts on other body systems. They're all integrated. So I don't think it's misleading to call it that, but I think it's important to recognize that COVID isn't the only, or SARS-CoV-2 isn't the only respiratory virus that has impacts outside of that system. But I think it is important from a classification standpoint to understand kind of where it fits, because that explains its transmission, that explains what countermeasures you use against it, and that really kind of situates it within a viral family that we know a lot about. So I think it's not the case that you're minimizing those other symptoms by calling it a respiratory virus, but I think it also allows you to understand a little bit about the transmission and other features of the virus, but also recognize that many other infectious diseases affect multiple systems, yet are characterized by their predominant symptoms or their predominant mode of transmission.
I want to ask you, and just because I don't want to lose this thought, but I just thought about the earlier response about um, the government's response and how it may have changed through the years. When it comes to vaccination, as someone who focuses primarily on emergency preparedness, have we sort of maybe lowered the role of vaccination when it comes to pandemic? It's crisis, it's all hands on deck, it's treating the severely ill. Uh, how would you characterize the role of vaccination in that whole mix?
Well, I think vaccination is a cornerstone of emergency preparedness. It's just that it took about a year, which was record time, to be able to develop a vaccine. So vaccine has to be part of the whole portfolio of measures that you put into place, which start with very simple things like testing, contact tracing, isolation, non-pharmaceutical interventions like masks and hand washing and increased ventilation in indoor settings. And then also, so then vaccine development, but also development of antiviral therapies or monoclonal antibodies. So it's part of the portfolio. But when you're thinking about what ultimately ends infectious disease outbreaks, it's often going to be a vaccine. That's going to be part of the solution for most. Obviously, there's some exceptions like HIV, but vaccination is a cornerstone to that. But it shouldn't be seen as the only thing, and it shouldn't be seen as once you've got a vaccine, everything is done, because a vaccine is not a vaccination. It's not in someone's arm, and it may not necessarily be durable in terms of mutations and new variants that occur. So you want to make sure that you have multiple different elements at play during an emergency response. And vaccines, I think we got lucky with Operation Warp Speed being successful, but we might not have had a vaccine. Prior to COVID-19, it took 4 years to make the fastest vaccine. So this was something unprecedented that allowed us to sort of get out of that acute phase faster. But it has to be part of a full body portfolio approach rather than just the only thing that you're counting on.
Legia, you shared so much powerful information in your testimony about how long COVID has affected you. I'm wondering if you could offer us some advice on how journalists can seek out those stories and present them in a way that doesn't perhaps even defeat the purpose by either being dismissed as scare tactics or among those who don't even really believe in COVID or don't think it's as serious as it could be. Give us some advice on, and particularly perhaps of the role of vaccination in that mix.
Sure. Yeah, I'd already planned to kind of partially answer the question that you just asked, Dr. Adalja, because I feel like that something that is really missing in the majority of reporting on COVID is an actual understanding of the virus. And so when you were asking about, is it dismissive or misleading, sorry, to talk about it as a respiratory virus, I would say that it's limiting in the public consciousness to call it a respiratory virus, because COVID is a multi-systemic disease that causes substantial death and disability. And so it's not just a respiratory virus. It can attack all bodily all bodily systems, especially including the cardiovascular system, as he already detailed, the lungs, the nervous system, the brain, and more. And this can cause permanent damage. And I feel like the things I'm going to go through quickly here are things that many reporters simply are not including in their stories. And so that is giving a misleading understanding of COVID to the general public, our readers, our listeners. So I dropped in the chat when Bennett was talking that the map of the CDC's wastewater testing, which is the identification of virus levels in sewage, since the virus is carried in feces, or is particles of the virus are. And it shows that COVID levels are very, very high in much of the country. And that even though we're, the summer surge has been going on for quite a while, we're still at 1 million people, an estimated 1 million people being infected in the US per day. So we're still at a real crisis level. And so to tack on to what Dr. Adalja was talking about, what he was describing in COVID conscious circles, and perhaps in scientific literature early in the pandemic, is called the Swiss cheese method, by which you have different mitigation methods, and all of them are imperfect. So they all have a bit of a hole, like a slice of Swiss cheese, but you layer all of them, and it provides a more robust protection than just vaccination. So I'm very, very, very in favor of vaccines. I'm a huge proponent and encourage everybody to stay up to date on their boosters. But the problem is that the single most important tool to prevent COVID is largely overlooked by the media and public health authorities, and this includes the CDC. And that's wearing a high quality, well-fitting mask or respirator. So that's namely an N95 with head straps or a KN95. And I find in the majority of reporting on COVID and long COVID, I never hear about masks at all. And so this is, we have this opportunity to inform and educate the public that is being largely missed. So in terms of N95 or KN95, they're superior to surgical masks because surgical masks do very little to protect you against COVID or to prevent you from passing on the virus to others. And cloth masks are also vastly inadequate. I do want to say that some people cannot afford to buy high quality masks. And because of that, local communities around the world have created mask blocks, which are organizations that give high quality masks away to members of their community free of charge. And anyone can find a mask block in your area on the website maskblock.org. That's maskbloc.org.
This is a very important in that Dr. Jackson and I in our early conversation talked about alternative and treatment or ways to protect ourselves need to be amplified more in the public. And I need to pivot now quickly because I just saw that Finnet added paywall-free frequently asked questions on the new COVID vaccines in the chat. So Finnet, I'm going to ask you to tell us about what you've produced and how it could benefit.
A lot of what's in that FAQ are some of the same issues that I covered in the top of my remarks. I would say probably the most common question that we get from readers is about the best time to get a new COVID vaccine. So Dr. Stewart at the top of it made a good point about how really from a public health perspective, you want people to get vaccinated. And I think sometimes what I hear from experts is that we may overthink the timing a little bit and that it's kind of a bit of an imperfect science to get the timing exactly right. But I do think that sometimes the people who are reading these articles do tend to be the more health conscious consumers who are going to get vaccinated regardless. So it's worth laying out some of the factors that people could consider. So what the data shows is that the efficacy tends to wane after 4 months. So a shot in September should still help you out by the winter wave, but usually there's a several month wait if you already got infected in the summer, or if you already got a second dose or your first dose of the 23-24 vaccine this summer, it may benefit you to wait up to somewhere between 2 and 4 months before getting a dose of the new vaccine. And then also the public health guidance is generally that you can get your COVID and flu shot at the same time, but the flu season may vary depending on where you live. Usually the optimal timing is September or October. There's a phrase like flu before boo, meaning you should get your flu shot before Halloween. But those are the kind of things that you can talk through with the doctor, because if you had COVID this summer, might make sense to get your your flu shot sooner and then your COVID shot later. So it can be a little bit more complicated than we sometimes think, and that's where journalism can help in walking people through the different trade-offs that are at play. Because often we tell people to talk to your doctor, but the reality is, like, a lot of people aren't going to be able, like, need 4 months just to get an appointment with a doctor. They go to a doctor and they're being rushed through, or the doctor only has like a surface level knowledge of these things. So it's helpful if we can connect people to the experts to help them inform their decision making, or to inform the questions that they can ask their doctor if they are able to get an appointment.
That's a very good point. Dr. Jackson, we have a question from Wendy Thompson, a freelancer for the New York Times, and she says, what's the role of vaccination for people with autoimmune diseases and disorders and other conditions that have a low response or no response to antibody reactions?
It's a great question. So if somebody's on immune suppressing drugs, they may have less of a reaction to those vaccines. In general, it's still a good idea to go ahead and get one. It of course, check with your doctor if there's any specific situations that may be unique to your illness. But by and large, you're going to get some protection from that vaccine. But as Lydia was mentioning, there are other ways that people may need to help protect themselves. I think one that is often overlooked in the media, and this is not a criticism, it's just there's so much to cover on, is treatments. There's been long-standing treatments for flu, Tamiflu, it can potentially help shorten the course of illness, maybe reduce the risk of severe disease. And then for COVID especially, and I know people are very familiar now with Paxlovid and Molnupiravir and those type of things. And those can cut the risk of severe disease by half or more if taken within the first 5 days of illness. Now, there's some drug interactions that you have to deal with, but that's a really helpful way of getting additional benefit. And then already covered very well. And I 100% agree that we need to be thinking about things like indoor air quality, ventilation, especially in crowded environments. Those small steps to increase the amount of clean air in a room can really reduce the risk of transmission across a group. And then, of course, masks are something that people can choose to wear at any time. Agree with you, all the better if you can be high quality, well-fitting masks. And we say that those are most important if people are at greater risk, like we were just talking about, or during times of greater transmission. Thanks.
Dr. Stewart, I know that obviously pregnant women and babies are a huge concern. People have that at top of mind in terms of when to get a vaccine. Will it harm the fetus? Will it harm my child? So what do you advise when you're working with families and mothers, pregnant women, about vaccination?
It's really important to realize that with pregnant women, you're protecting not only yourself, but also your infant child. And so it's important for certain vaccines for you to be able to get those while you're pregnant. The RSV is, very I mean, it's just at high risk during the winter months. And if you're due to deliver during that time, there are certain stipulations as far as when you would receive the vaccine if you are pregnant to protect your baby. For the flu vaccine, again, it's the only way for those individuals, you're going to have a baby that's going to be less than 6 months. And so it's important for you as a pregnant mom to protect your baby. So I always encourage my pregnant moms to talk to your provider. This is something that, OBs do, family medicine, because we do treat and deliver infants, that we are on the front line for being able to provide that trusted information for our pregnant moms to protect our infant childs. And so for moms, of course, it's important to ensure that your baby 6 months and above is vaccinated. We have seen, and I know we've commented on this, the low rate of uptick in vaccinations in our young. School is beginning, and right now we're seeing an increase in our little ones, who I call cesspool of germs, coming home and with COVID, coming home with flu. We also are seeing RSV. It's important to realize that vaccination is one of the key ways to prevent serious illness and hospitalization and death. Also, and someone mentioned, and I can't recall who, so forgive me, the importance of mask wearing. And, for our young who, may not be able to wear a mask or find it uncomfortable, just having that conversation with the adults and saying that, again, recommendations of masks. We know how politically charged mandating masks are. And so within my office, I always say that we recommend one to wear a mask because we do not want to have anyone who is at high vulnerability for serious disease to contract a disease within our offices. So we recommend mask wearing, and our patients do not have any issues with that, because again, we try to meet them where they are, to talk to them about how important vaccines, masks, social distancing, all these things that we have talked about for the last couple of years are really important to decrease the community involvement of COVID and other respiratory diseases.
I want to ask Dr. Adalja to help us sort of get our arms around flu. I was telling Dr. Jackson last week, I get my flu shot every year, and yet I talked to a friend just last week who said she got hers a couple of years ago and it made her so sick she refuses now to get it ever again. And we're all of a certain age where severe illness might be more of a threat to us. So tell us how you, from your perspective, gauge the necessity for people to take flu more seriously, perhaps.
Well, I think when you look at infectious disease threats, flu is a perennial one that kills tens of thousands of Americans every year. And that's something that people aren't really aware of. They don't recognize it because it's something that's familiar, that's sort of baked into life. But flu also causes stress on hospitals. I'm an infectious disease, critical care, and emergency medicine doctor, and I work 50% of my time, and I'm in the hospital at that time and feel the pressure that a rough flu season can cause. So I think that people have lost appreciation for what it is. Maybe because the 2009 pandemic of H1N1 wasn't as severe as people predicted, that got people complacent, and our flu vaccines aren't the best shots. They're not as great as measles vaccines, for example, and there sometimes are mismatches. But I think what we have to recognize is that flu vaccines are the way to blunt the impact of it. It doesn't completely remove the impact of influenza, but people who get influenza vaccines are less likely to be hospitalized, less likely to die, less likely to have as much absenteeism or be down, even when the vaccine is mismatched. So I think it's about kind of concretizing the benefits that an individual gets from the flu vaccine, even if it's not perfect. And I think that's how I've always approached it with patients, that this is a way to kind of give yourself more resiliency than you would have otherwise during during what can be, a rough flu season. And I think that we do need better tools for flu. And I think that there's always been this quest for a universal flu vaccine, better antivirals. All of that stuff is part of the equation for flu. But I think it's something to recognize that because people, what I recognize is that because people think of flu as ordinary, they don't actually pay it the respect that it's due. But the biggest pandemic threat we face is influenza, and we're in the midst of an avian influenza outbreak amongst cattle that should be thought of as a trial run. We take flu very seriously in the pandemic preparedness world, and I think that the more respect we have for seasonal influenza, the better we're going to be for pandemic influenza. And I think we've got to start using the tools and showing people how they actually improve their lives during a flu season.
Thanks for that. Legia, you shared a lot of tremendous resources and people that journalists can connect with to learn more about long COVID and these issues. So we're going to make sure to share them widely. But could you quickly tell us or give us some advice for a journalist who's looking for someone perhaps to tell that story? And again, a way to do it that is compassionate, contextual, et cetera.
Yeah, this is really important because people with long COVID are dealing with so much in their lives. So the first thing that I would say is always to educate yourself about long COVID and about ME/CFS, which is myalgic encephalomyelitis or chronic fatigue syndrome, which overlaps a lot with long COVID and has a history of being really ignored, which is something that a lot of people with long COVID deal with. So I'd say first find out if your editor will let you use anonymous sources, because a lot of people who have long COVID are really afraid of that being public. And so if you can offer them anonymity from the beginning, that will make a difference in how easy it is to find people. And in terms of finding people, all long COVID organizations will be really happy to help you find sources who have long COVID. You also can ask around in your networks, because there are a lot of people with long COVID who either may not be identifying that way publicly or may not have quite figured it out themselves. So just ask people, do you know anybody who hasn't quite been themselves since having COVID? And something that I really encourage reporters to do is to look for diverse sources, because women, Black and brown people, trans people, as well as other members of the LGBTQ plus community, and people from lower socioeconomic brackets are hardest hit by long COVID. So it's important that their voices get out. And then in terms of actually interviewing, I always offer accommodations without making sources ask for that, especially when dealing with people who have long COVID or other disabilities. And this is really essential because long COVID is an energy limiting illness. So it makes it so that people are basically drained all the time. So I always offer, you can either do the interview by email or text, by voice memos. I send you a list of questions and you respond by voice memos, and those don't have to all come at one time, a phone call or a video call with or without video, because some people don't want their phone number to be public, and also to give people the option of not doing it all at one time, because an hour interview, which is what reporters really might require, may be too much for people. Sorry, they may only have energy for 30 minutes. So you can say, let's do 30 minutes today. Then the next time that you can do an interview, we'll do another 30 minutes. And the last essential piece that I'd say for reporting on long COVID and getting it right is to talk to reputable, trusted scientists and clinicians, because there are debunked theories about, for example, long COVID being a mental illness and not a physical illness, or long COVID being curable by exercise, which is actually highly contraindicated in people with long COVID because it can make them much sicker permanently. So do your due diligence and look for reputable sources when you're doing your reporting.
This is incredibly important information, and I thank you for sharing that. We are nearing the end of our discussion, but I'd like to ask each of you to sort of give us that takeaway, take it home statement about vaccination, about the fall respiratory illness season, and the most important thing they should take away. But Dr. Jackson, I'm also going to ask you to talk quickly about the whole insurance situation. Someone mentioned earlier that during the height of the pandemic, it was free. Run, get your vaccination. And now there are some situations that people need to keep in mind in terms of whether they're covered. So could you quickly tell us that and then sort of give us your takeaway message?
Sure. And I'll preface it by saying insurance is not really CDC's thing. There's other agencies in the government that deal with that. But what I will say is that by and large, these vaccines should be covered by for anybody with private insurance. You may need to check if, for instance, if you're going to a pharmacy, if that's in network for your insurance provider. You know, generally in clinicians' offices, it's less of an issue. I know there's been a lot of work done to try and improve reimbursement in nursing homes. We know that the uptake has been way too low there and not protecting enough people. And so doing what we can to lower those types of barriers. Just in terms of messaging for the fall, you know, I know people are tired of hearing about this. I know people just don't even want to hear about COVID a lot of times. I don't mean to overgeneralize here, but a lot of people are just sort of mentally done with it. I think we need to, instead of looking back to where we were with the pandemic, look forward to protecting ourselves and those around us. I think what Fennett mentioned as well about these vaccines, while they're not perfect at preventing infection, they do help lower that and still add that additional layer of Swiss cheese that Ligia mentioned. So I think that plus combined with these other measures, we can save a lot of lives this coming season. The last thing I want to say, and this is relevant to what Dr. Adele just said, is peak hospitalizations and peak illness now in the winter season is now going to be worse pretty much every year going forward than it was before the pandemic. Because before we had the two major illnesses with RSV and flu, you had COVID on top of that. Even if it's not its emergency self, it is still a bad disease. You add those three together and we can end up with very full hospitals, clinics, and a stressed medical system. So do what you can to protect yourselves and others.
Dr. Stewart, in your summary, I'd like you to also just quickly speak to the issue of misinformation. And I'm sure that you deal with that a lot with the patients that you see. So what takeaway message would you give us about staying informed and avoiding misinformation?
Yes, thank you so very much. And, you know, it's really important. Every day, I have to talk to my patients about information they have received outside of the four walls of our exam room. And it's important for patients to look at those trusted resources, places like the CDC. Places like the American Academy of Family Physicians, as well as the American Academy of Pediatrics, for their information regarding vaccines. Family physicians are one of the trusted sources of information regarding vaccines, as well as any other preventable illnesses. We know that, and it has been proven that vaccines are safe, and it is the most effective way that we have right now to prevent items such as hospitalization. We talked about long COVID. It does not eliminate it, but we know that we are seeing lesser cases with those individuals who are vaccinated. And then it's important, as Dr. Jackson mentioned, there are still health inequities out there. And I see those in my clinic every day, and that we have to keep those first and foremost. I work at a community health center where many of our patients don't have insurance or have very little. And many times these individuals are missed and not really looked upon as, you know, ensuring that they receive treatment if they have COVID-19 as well as the vaccine. So important note is that vaccines are safe and effective. And it's important to recognize that family physicians, as well as other healthcare providers, are those trusted resources that you need to look upon to get any information regarding vaccines.
Thank you for that. Dr. Adalja, as we wrap up, and again, from your perspective and expertise, please send us a takeaway message about masking and air quality and other things that people can do that might seem a little less complicated than running out and getting a vaccine, but can be equally effective.
Well, I would argue whether or not they're equally effective, but I would say that you have to think about your protection against respiratory infections as part of a multi-layered approach. I think we just heard the concept of Swiss cheese. And there are some low-tech interventions, things like we talk about what we call non-pharmaceutical interventions that are ways of lowering your risk. And you kind of sort of have to think about them almost the way you think of an umbrella in a rainstorm, that these tools are out there and you can use them to decrease your risk of acquiring a respiratory virus or passing along a respiratory virus. There are well quality made masks that are available to anybody that wants them, N95 or N95 equivalents when they're in crowded, congregated areas, especially if they're in a high risk group. There's been a major push to increase ventilation in buildings, and even just opening a window increases the amount of air exchange that makes transmission less likely when you have people congregating. So I think it's important to think about, that we have the very high-tech tools that science and medicine have given us: home tests, vaccines, antivirals, monoclonal antibodies. And we also have low-tech tools that we know work. And by using all of those things together, coming up with kind of a kit to use during respiratory virus season, I think you can minimize your risk of transmitting or acquiring an infection. And remember, those viruses are going to be there. That you have to, anytime humans are congregating, this COVID, RSV, influenza, adenoviruses, metapneumovirus, all of those viruses are also congregating with you. It's sort of part of the human condition. And I think we've got a lot of knowledge to be able to minimize the impact that they have on individuals' lives. And I think that people should think about using those tools. And it's not one size fits all. It's not always going to be the same for every person. Each person's risk tolerance is going to be different, and in each situation is going to be different. So it's important to know what those tools are and use them as needed, as it suits kind of your individual risk tolerance.
Thank you. Legia, give us your takeaway message for journalists who hope to produce content that can really make a difference in people's lives.
I actually would like to use my time to ask a question of Dr. Jackson about the CDC's messaging around masking. Earlier this month on the CDC's Instagram, there was a post it was a jokey meme about COVID flu and COVID-19 waiting for everybody as they went back to school. And vaccines were mentioned, washing hands were mentioned, testing was mentioned, but there was no mention of masks or air filtration. But because masks are so effective, I'm wondering if you could explain why the CDC isn't actively recommending them.
Well, I will say, for one, CDC is actively recommending them. We've got a respiratory virus page that outlines all the protective actions that people can take, and that is certainly on there. I can't speak to every social media post that goes out, but totally agree that those should be mentioned in association with the others. I know online a lot of posts can kind of spiral up in a lot of circles. It certainly is not meant to devalue masks in any way. We know that they're an effective tool when people choose to use them.
Dr. Jackson, thank you for your response. And Finnett, let's wrap up by sort of giving us your takeaway message for journalists. You're on mute.
Sorry. I think for journalists covering the fall vaccine campaign, I would just urge that our primary role is to offer context, and that when people are reading our work, think about how we can provide a value add from the public health messaging that people are going to see. And that context is going to involve providing statistics about the circulation of COVID in your community and what we know about how it's acted in the summer wave and how it's acted in winter before. It's also helpful I think it's also really important when we're writing about COVID to not be judgmental to readers and to be mindful that a lot of people are knee-jerk dismissive because they think media is fear-mongering. And I think that's where taking more of a neutral tone and using restrained language is really helpful. We should acknowledge that we are not in the same kind of acute phase of the pandemic that we were earlier, where we're seeing hospitals overwhelmed and morgued and seeing thousands of deaths a day. But at the same time, in a fall and winter respiratory season, when there's people coming in with flu and RSV2, hospitals can end up getting getting strained as a result of COVID upticks as well. And while COVID doesn't have the same kind of severe outcomes it does, as we've talked about today, long COVID is still a factor, and that can lead to long-term debilitating effects, even if people aren't in the hospital. At the same time, one of the major risk factors for long COVID is severe illness, and that's why you hear experts talk about how vaccines have a value beyond just keeping you out of the hospital, because it can reduce the kind of and the symptoms or the infections that can lead to long COVID. But also, COVID can just be flat out unpleasant and inconvenient too. From a personal level, I get my COVID shots timed so that closer to Christmas, because I don't want to be sick during Christmas, and I don't want my holiday plans ruined. So as a reporter, I try to emphasize the different reasons that there's a value in getting vaccinated, and I try to be honest about what we know and what we don't know. And I think providing that context and avoiding a judgmental tone goes a long way in building reader trust when writing about these issues.
This has been an incredibly important and valuable conversation for me specifically, and for all the participants and viewers who've watched in. So I want to take this opportunity to thank our panelists, Dr. Brendan Jackson of the CDC, Dr. Ada Stewart, Dr. Amesh Adalja, Legia Navarro, and Finit Nirapil. A wonderful exploration of expert journalists and researchers and doctors. Thank you all so much for being with us. And we'd also like to thank our sponsors once again, the Champions for Vaccine Education, Equity, and Progress, for their continued support of NPF's goal of making good journalists better. Thank you all for tuning in.